So going through again, no disclosures from either past or present, going through this. So benzodiazepines in a primary care setting, no disclosures. We're gonna start with, I'm gonna go right into it. Gonna start with a little question, right? If someone feels, just, well, we're recording. So, just maybe chat in if you think about it. If you think you know the answer, or maybe just reflect on it. Think about what you might say, the answer to this is, if you were taking an exam and this was the board exams. What percentage of patients prescribed benzodiazepines will go on to use them for over 12 months? 55%, 45%, 35%, 25%, and 15% are answer choices. So just reflect upon it. We've got a couple of people writing in. We've got 45%. Someone writing in. Okay, so we're gonna keep going. Just think about this. The answer will come. So in terms of indications, benzodiazepines really are indicated for short-term use for a variety of things. Maybe that acute 2 to 6 week treatment of anxiety disorders, but not really post-traumatic stress disorder. Short treatment of insomnia, again, muscle relaxant, also in an acute setting, a couple of weeks at most, acute psychosis with agitation. Alcohol withdrawal, particularly in outpatient settings, they still remain sort of the mainstays of treatment. Treatment of acute anxiety generator. For example, before an MRI, if a patient's gonna have an MRI and they're feeling anxious about it, benzodiazepines could be a great sort of medication for that. Seizures, status epilepticus, as well as sedation for office procedures. So in none of this, as you see, we're talking about long-term use for anxiety disorders, right? Which is kind of what we unfortunately often wind up seeing with our patients. So if you think about it, the biggest prevalence of concerning benzodiazepine use is seen in patients who are also concurrently have opioid use disorders. So for example, in opioid maintenance treatment, our patients are on buprenorphine or methadone. 46 to 71% of these patients use benzodiazepines concurrently. And if you think about youth, the transitional age kids, 18 to 29 with opioid use disorder, that's really what OUD stands for, is opioid use disorder. Over 80%, 85% will report having used these medications over the course of their lives, and over 60% report regular use. So that's sort of a take-home point, that opioid use disorder and benzodiazepine use disorders often go hand in hand. But the benzodiazepine use disorder independently of it is actually relatively uncommon, right? So oftentimes when you see someone having a problem with benzodiazepine use disorder, you should think about whether that person also has other substance use disorders, because very often they will. And the most common other substance use disorder seen is opioid use disorder, right? Now, if you think about long-term use for everyone that's prescribed benzodiazepines, actually about 35% will use them beyond 3 months, 15% over a year, and only 5% over 8 years, right? So kind of surprising, right? When I initially saw this, I also picked 45% or 35% because those are the patients we often see. But the reality is that across the country, if you look at all the people who are ever prescribed benzodiazepines, vast majority of them will only use them for short term. Only about 15% will use them for over a year, and about 5% over 8 years. But I think very often those are the patients we wind up seeing, and those patients are also challenging because they have other substance use disorders, other psychiatric comorbidities, and so we often wind up focusing on that cohort of patients. Many side effects to benzodiazepine use. Worsening of depression, emergence of depression, over-sedation, motor impairment, slowed cognition, amnesia has been very clearly shown with benzodiazepine use. Slurred speech, ataxia, impaired gag reflex, and pterograde amnesia, meaning that when people are on benzodiazepines, particularly at high doses, they have difficulty incorporating new information, forming new memories, right? Learning difficulties, impairments in attention and concentration, falls in elderly. Benzodiazepine use is significantly related to falls in the elderly, which is obviously a big concern. Risk of dementia, cognitive decline across domain has been shown with benzodiazepines. And then in the last line, I put a question mark next to increased mortality. Why did I do that? Well, so going back to about 2009, a number of papers came out of Britain, really, that showed an association that people who had taken benzodiazepines over the lifetime were actually, there was an association between that lifetime benzodiazepine use and increased mortality. So if I was giving this talk 5 years ago, I would not have had that question mark, because it really seemed to be the case. But more recently, over the last couple of years, studies have come out showing we're not so sure, we don't know what's going on, we don't even think that association is there. So we don't know. I think more studies need to be done. But still, as you can see, even if you take away that increased mortality, lots and lots of side effects. And benzodiazepines, particularly alprazolam, in the United States, right, alprazolam being Xanax, are not uncommonly found in postmortem toxicology in the cases of unintentional drug overdoses. So that was question 2. Again, think about this. Patients who become dependent on therapeutic doses of benzodiazepines have all of the following characteristics except, this is one of those classic except questions. They continue to take the benzo even though their original medication is no longer indicated. Dose was increased, right, since the original prescription. They have disliked the sedative effects. They have taken prescribed benzos at therapeutic low doses for months or years, and they gradually came to use the medication for other needs, right? So let's think about this. Look at this question for a second, see if you can come up with an answer, and then I'm gonna keep kind of moving forward. Someone says number 3, they have disliked the sedative effects. That is actually the correct answer. So good. So there was a prescription use behavior questionnaire that actually discriminated between these two groups, the group that was using benzodiazepines therapeutically and the group of people that were using them in a non-medical manner. And I think this is fairly intuitive, nothing groundbreaking here. What they found is that the group that was likely to wind up using benzodiazepines in a non-prescribed manner tended to use more than prescribed, use more often than prescribed, call for early refills, often seek multiple providers, multiple doctors, right? Use when feeling upset, use to get high, use for the euphoria. Some of those things were associated with misuse of benzodiazepines. So this is sort of not based on any particular paper. This idea of benzodiazepine doses and them being in a green light zone, orange light zone, or red light zone really came from Dr. Richard Rees, who's an addiction medicine physician over at University of Washington. He really came up with this idea initially. And I like it because it's a good general idea. So green light zone is people who are taking half or less of the maximum dose listed in the PDR. And usually these are patients who don't have an addiction to benzodiazepines, but are using it appropriately to treat anxiety. Orange light zone is somewhere in between, from half to maximum dose listed in the PDR. What we know is that most people with anxiety but no underlying benzodiazepine use disorder do not require doses in the orange light zone. Most of them actually tend to do okay at those green light zone doses. And then there is the red light zone, which is higher than the maximum PDR dose. These are patients with substance use disorder. These are the patients that Dr. Jacobson and I and Dr. Maley and Clark see, right? Very often, and maybe you guys see as well in your practices, right? And our patients can reach these doses extremely, extremely quickly. And this is just a reference slide that has listed green light, orange light, and red light zones for many of the common benzodiazepines. So you can think about alprazolam, for example. The green light is under 2 milligrams. The common dose at which I see my patients on alprazolam is 3 times that, right? 2 milligrams 3 times a day seems to be a very common dose I see, sometimes even higher than that. So you can see how risky that dose can be. So how do I help? Look at the time here. Good. We've got about less than 10 minutes, so I'm going to go right into it. All of the following treatments carry evidence as adjuncts to a benzo taper, except, another except question here, cognitive behavioral therapy, which we learned about last week, we talked about, imipramine, carbamazepine, risperidone, or sleep hygiene. All of these have evidence to help with tapers except So if any brave souls want to throw out a number on the chat, you're welcome to do so. Someone said 4, right? We've got a 2, so we've got a little disagreement here. So the correct answer is 4. Risperidone does not carry any evidence. All of the other modalities listed here do. Stepwise approach. So the first approach, of course, is prevention. Keeping patients from becoming dependent on benzodiazepines in the first place. So don't use benzodiazepine as first-line medications, and especially in the population that have other substance use disorders. The data is very clear. Benzodiazepines should never be used as a first-line medication in this group of patients. And if they are started, they should be used as a bridge. So I'll tell my patients ahead of time that we are starting this to get your anxiety under control very quickly, but we will only be using it for the next 3 weeks, 4 weeks, whatever, until your other medications, until the psychotherapies, until all the other wellness things you are doing, maybe mindfulness, right? Maybe acupuncture, maybe yoga, all of those things become effective, right? So they're only used as a bridge in a time-limited fashion. Before starting them, just like with our prescription opioids, we should be checking urine drug screens and the prescription monitoring profile, right? Avoid in elderly. They should be avoided in the elderly, should be avoided in individuals with substance use disorder, and on patients on opioids. CDC guidelines clearly mention this, right? And recommend against co-prescription of benzodiazepines and opioids, which can be potentially very dangerous or even fatal. Encourage other means of anxiety control that we've talked about. Then, so after prevention, we've got brief interventions, and believe it or not, they tend to be effective. So it's been found that provision of simple advice and information on how to reduce the dose can actually help many people initiate a taper. And this was reviewed in a New England Journal of Medicine article from about 3 years ago, where they basically took patients on high doses of benzo, gave them individualized information on the dangers of this medication, on how to do a taper, and whether in person or via personalized letter, actually pool odds ratio was 2.8. So patients who received this information were about 3 times more likely to say, hey, doc, can you help me taper off of these medications? Kind of amazing, right? Without just that simple information provision was helpful. In general, some general principles of taper, this usually needs to be slow. If you taper too quickly, rates of relapse are very high, and there are dangers, right, such as seizures and severe withdrawals. So usually over several weeks. And generally we say 10 to 25% every 1 to 2 weeks is a general kind of ballpark figure for this taper. So if we go that way, you really can, for many patients, about 8 weeks or so, carry out many taper, but some might even require longer. Generally, if someone's taking multiple benzodiazepines, there is good deal of evidence that you want to combine them into one medication for the taper. In the United States, clonazepam tends to be used widely. In Europe, that tends to be diazepam. In general, we tend to use these longer-acting benzodiazepines with the idea that it's going to be easier to taper them than a short-acting medication such as alprazolam. But the evidence actually is quite mixed on that. There is not a whole lot of evidence, but it is a common practice, right? You generally want to stick with a relatively fixed taper schedule, clear guidelines, clear expectations. And if someone's on very high doses, you want to consider inpatient taper. And generally, it's not, the success rate in words of people able to taper off successfully tends to be about 60% overall, which is not terrible, right? Then what we did was broke it down into different categories, and looking at the time here, because every patient is different. So first group, patients who have who are taking benzodiazepines because they have a psychiatric illness, but do not have a benzodiazepine use disorder. They're taking them therapeutically, right? So I'm actually gonna skip over the vignette because I just wanna hit the major points in about 3 minutes or so. So with this group, right, generally, they're taking medications as prescribed. They may have tolerance if they've been taking them for a long time. So usually, treatment options, which I put in red, is to continue treatment, monitor for side effects and aberrant behaviors, and gradually taper as tolerated if long-term use. And this is the patient, Clark, you were talking about. Patients who come to you and the psychiatrists say, well, it's helping them, let's continue, right? And that may be a reasonable strategy in people who are taking those green light zone doses, have underlying psychiatric illness, and don't have other aberrant behaviors. Again, similar to our patients who might be on opioids for pain. Then there is this second group. This is the group that's got a primary psychiatric illness, right, such as generalized anxiety, but over time, they also developed a benzodiazepine use disorder. I'm skipping over the vignette here again. So in general, so initially they were prescribed the medication for their underlying psychiatric illness, but over time they came to rely on it. They started using more and more doses, right? Sound familiar? Maybe started seeking them from outside sources illicitly, and their doses kept escalating. Maybe at some time they tried to taper, but when they tried to taper, their symptoms, the underlying anxiety came back, so they got scared, right? And then they stopped attempting any taper. So here, in general, these are the patients who say, doc, the only thing that works for me is that benzodiazepine. That Xanax is the only thing that helps me. Sometimes I drink alcohol with it because that also helps my anxiety. There's nothing else that's going to help me. In this group, if you try to taper too quickly, guess what? It's not going to work because that anxiety is going to get bad and they're just going to stop treatment with you, right? Because as the anxiety comes back. So oftentimes you want to taper over several months. And for some of these patients, the goal may not be complete discontinuation. Rather, you lower them as much as possible, usually 25% of their original dose or a milligram or so of clonazepam a day, and maintain them at that dose under careful supervision. And I listed sort of a step-by-step strategy. Again, first we switch them over to a single long-acting benzo, then you stabilize it for 2 to 4 weeks, and then you taper over 6 to 8 weeks, right, to about a milligram of clonazepam or so, and then you might keep them on it for the next several weeks. And then when the patient is ready, when anxiety is under good control, then you make that final push to see if it works, right? So that's often the strategy used. And this is where all these other things come in, right? Relaxation, traditional modalities, CBT is extremely effective, right? Other medications such as SSRIs, SNRIs, valproate, imipramine, the structure, monitoring the patients closely. And finally is the group with a primary substance use disorder and a benzo use disorder. This is like the patient I saw not too long ago who came in saying, I take as many Xanny bars as I can get, and was in fact taking up to 30 milligrams of alprazolam a day. These patients are very high risk for withdrawal seizures. And very often, these are the patients that we are going to admit to the inpatient unit, right, for detoxification from all drugs. Remember, these patients may also very likely also have a concurrent addiction to opioids. And if that's the case, in an ideal world, they get admitted to an inpatient setting, they're rapidly tapered off of the benzodiazepines, and before discharge, they're started on buprenorphine or long-acting naltrexone, and that care is continued in the outpatient setting, right? And while they're inpatient, ideally, we also start addressing their underlying psychiatric illnesses, right? And many things have been looked at. Carbamazepine, for example, has been studied on the inpatient basis. Valproate has been studied on the inpatient basis to help with these very complicated benzodiazepine tapers that I've listed. Things that work, there is no approved medication to aid with the taper. Carbamazepine has been the most studied. Generally, they're started 200 milligrams twice a day up to 400 twice a day, and the medication will be continued for several weeks, even after the benzodiazepine has been tapered off. Valproic acid, pregabalin, has been tried at up to 600 milligrams a day to help with benzo tapers. Gabapentin, imipramine tends to be quite effective in helping our patients taper off of benzodiazepines, right? And again, you want to at the same time start treating the underlying things, such as anxiety, such as insomnia. There is no evidence for antipsychotics, although sometimes I do see them used. CBT, I know we talked about this a lot last time, but is one of the most effective strategies we have for patients who are undergoing benzodiazepine tapers for them to be in cognitive behavioral therapy. And especially if insomnia is also present, which it often is, if they're placed in CBT, the odds ratio of them completing detox is over 5. In other words, if they receive CBT, they're over 5 times more likely to actually successfully complete a benzo detox, which is one of the biggest evidences we have for any treatment modality. So it should always be considered. I've listed some other step-by-step approach. This is taken from the New England Journal article that lists the different strategies as well as the level of evidence, right? I've listed that as well as an equivalency chart, and I will end here.